Travel can expose an individual to new people, places, and experiences, but it can also expose them to new illnesses. When the following patient presented at the ER after a recent long trip, there was a lot to unpack.
A 26-year-old woman recently spent 3 weeks in Puerto Rico enjoying hiking, swimming, and exploring various caves. Soon after the 5-hour flight home, she noticed chest pain that started as a dull substernal pressure and progressed over the following week to a stabbing pain that worsened with deep inspiration and coughing. She presented to the emergency department with a feeling like her heart was racing. She had no fevers, chills, shortness of breath, wheezing, or bloody sputum.
The recent long plane flight, sharp, stabbing chest pain, and a rapid heart rate raise alarms for a pulmonary embolism. More information about her medical history will be useful.
She had no history of venous thromboembolism, cancer, or environmental or drug allergies, and did not use oral contraceptives, which can increase the risk of a blood clot. Her mother had rheumatoid arthritis, but there was no family history of blood disorders. She did not smoke, drank 1 to 2 alcoholic beverages per week, and was in a monogamous relationship.
Physicians can assess the clinical probability of a pulmonary embolism, or PE, using a risk calculator known as the Wells score. A frequently used and validated tool that can be rapidly applied at the bedside, the score considers factors including clinical signs or symptoms of a deep vein thrombosis, tachycardia, a recent prolonged period of immobilization like a plane flight, a prior DVT or PE, coughing blood, and a history of cancer.
Her Wells score was 1.5 points. On physical examination, she was afebrile with a fast heart rate. Her blood pressure was a little low, and she was breathing comfortably. Her heart, lung, and abdominal exams were normal. She had no swelling or tenderness of the lower extremities. A D-dimer level was slightly elevated, only at 583 nanograms per milliliter.
A Wells score of 4 or less indicates that PE is unlikely. In scenarios where PE is considered unlikely, a blood test known as a D-dimer is also helpful. A normal D-dimer level, when there is a low suspicion for PE, can effectively rule out that diagnosis. Elevated levels don't imply that a PE is present, but require additional testing. A reasonable next step is to obtain a CT scan of the chest with contrast to evaluate the pulmonary arteries for a clot.
The CT scan did not reveal findings consistent with a pulmonary embolism. Enlarged lymph nodes are seen in the mediastinum and the hyla of both lungs, which may be seen with an inflammatory process. In the lungs, there were diffuse ground glass nodules and trace pleural effusions, or fluid collections around the lung.
D-dimer may be elevated in cases of infection, inflammation, and malignancy, even in the absence of a pulmonary embolism. The evidence of lymphadenopathy, or swollen lymph nodes, and diffuse ground glass nodules suggest a developing infection or underlying inflammatory condition. These findings are concerning, and at this point, she needs to be evaluated further and receive treatment for her pain.
She was admitted to the hospital, and within 10 hours, she developed a low-grade fever, and levofloxacin was prescribed for presumed bacterial pneumonia. Cultures of blood, urine, and sputum were negative. Serologic analysis for HIV infection was also negative. A complete blood count was obtained and showed no abnormalities. Serum chemistries, including renal function, were also normal. However, the erythrocyte sedimentation rate and C-reactive protein, both markers of inflammation, were elevated.
Elevated inflammatory markers can be seen in infection and inflammatory disease like sarcoidosis. While most cases of pneumonia are caused by typical or atypical bacterial organisms, viral or fungal pathogens can cause similar findings to those seen on her CT scan. Her recent travel to Puerto Rico may suggest atypical causes of infection from exposures on her trip. She mentioned swimming, hiking, and splunking. We should collect more information about where she engaged in these activities.
She revealed that the caves she visited in Puerto Rico were densely populated with bats. Their droppings, known as guano, carpeted the cave floors.
Guano, or bat excrement, is a nitrogen-rich waste product that is used as a fertilizer. It can also contain a fungal pathogen, Histoplasma capsulatum, which thrives in humid soil enriched with bird droppings and bat guano. It is common in many regions worldwide, including the South and Midwest United States and Puerto Rico. Activities like caving, cleaning chicken coops, and construction work have all been linked to outbreaks of histoplasmosis. Symptoms include fatigue, cough, fever, and chest pain, though many cases are asymptomatic. A diagnosis of histoplasmosis could explain her symptoms, but confirmatory testing is needed.
Histoplasmosis serologies and urine histoplasmosis antigen tests that were sent were both negative. Biopsies of the right mediastinal and hilar lymph nodes were obtained by means of endobronchial, ultrasound-guided fine needle aspiration.
Making a diagnosis of histoplasmosis can be challenging. Fungal serologic testing has limited value. A positive test result does not necessarily mean acute infection, as it can reflect prior exposure unrelated to the present illness. Culture of induced sputum can take weeks to grow histoplasma, if it grows at all. A positive urinary or serum histoplasma antigen would support the diagnosis, but it can take days to return, and a negative test does not exclude the diagnosis. Despite its challenges, histopathologic sampling and culture is considered the gold standard for diagnosis.
Histologic analysis of the mediastinal lymph node biopsy revealed necrotizing granulomatous inflammation, as is characteristic of fungal infection, as well as yeast forms that were subsequently confirmed on culture to be Histoplasma capsulatum.
While most cases of histoplasmosis resolve after a few weeks without treatment, an oral antifungal agent such as itraconazole is the treatment of choice for patients with moderate to severe illness. IV amphotericin B is reserved for patients with life-threatening infections, seen more frequently in immunocompromised patients, such as those with AIDS. Pleuritic chest pain is best managed with nonsteroidal anti-inflammatory drugs.
She completed a 12-week course of itraconazole with resolution of her respiratory symptoms and pain.
Acute pulmonary histoplasmosis can cause a variety of both localized and systemic symptoms, and is not always easy to diagnose, even with extensive clinical testing. And, as this case demonstrates, physicians should always remember that travelers may come home with more than just souvenirs and memories. So when an ill patient tells you that they have recently been on the road, you should ask for a thorough exposure history right off the bat.